Scott Brown's Rhinology, Chapter 91, Allergic Rhinitis. Today we are discussing Introduction, Definition, Prevalence, Natural History, Presentation, Examination, Diagnosis. Introduction. Allergic rhinitis is characterized by inflammatory changes in the nasal mucosa caused by exposure to inhaled allergens. It is a common disease affecting between 0.8 to 39.7% of the world's population, depending on location, with prevalence in Western Europe of 23%. It causes significant disability and is poorly managed. There may be comorbidities with other organs being involved, commonly the eyes causing allergic conjunctivitis and the lungs with allergic asthma. Indeed, these diseases are increasingly considered to be a single entity with a spectrum of respiratory allergic response termed the unified allergic airway. They have a common epidemiology, pathophysiology, and in many cases, treatment approach. Allergic rhinitis and allergic rhinoconjunctivitis are caused by an inflammatory response to an allergen to which the patient has already been exposed. In this abnormal response, the individual has produced allergen-specific immunoglobulin IgE, which binds to mast cell surface receptors. Subsequent allergen response causes this receptor or IgE complex to trigger mast cell degranulation with the release of preformed mediators. This inflammatory mediators release includes not only histamine but also other granule contents, serine, proteases, heparin, and newly synthesized eicosanoids mediators, leukotriene C4, prostaglandin D2, thromboxane, and PAF. For further details, please see Chapter 14, Allergy, Basic Mechanism and Tests. These inflammatory mediators cause the classic symptoms of allergic rhinitis: nerve irritation causing sneezing and itching, loss of mucosal integrity causing rhinorrhea, and vascular engorgement causing block. Histamine drives the majority of acute nasal symptoms such as sneezing and itching, with leukotrienes and prostaglandins being involved in longer term symptoms such as block. Definition. Rhinitis is defined clinically having two or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, and or itching of the nose during 2 or more consecutive days for more than 1 hour on most days. Allergic rhinitis is described when these symptoms are caused by allergen exposure leading to an IgE mediated reaction. Allergic rhinitis is subdivided into intermittent IAR or persistent PER disease and the severity into mild, moderate, or severe. These definitions are not interchangeable with the terms seasonal and perennial and were introduced to relate the patient's symptoms rather than an allergen to diagnosis. In one large study of people with allergic rhinitis, 10% was classified as having mild intermittent rhinitis, 14% mild persistent rhinitis, 17% moderate or severe intermittent rhinitis, and 59% moderate or severe persistent rhinitis. Therefore, approximately 75% of the patients will be diagnosed as having a persistent rhinitis and 25% of intermittent. Whether the disease is classified as mild or moderate or severe depends on the effect of the patient's social life, work or school, and sleep. The sleep disturbance is common fact in patients with moderate or severe allergic rhinitis and may lead to daytime sleepiness. This is also linked to problems with learning at school and examination success in children, and time off work and loss of productivity in adults. Patients with non-allergic rhinitis may have similar symptoms which are discussed in other chapters. Infectious rhinitis, occupational rhinitis, drug-induced rhinitis, hormonal rhinitis, irritant rhinitis, mucositis, persistent non-allergic rhinitis with eosinophilia, nares, and idiopathic vasomotor rhinitis. The diagnosis of an allergic rhinitis is made by correlating the allergic symptoms and the history with diagnostic tests demonstrating allergen-specific IgE, whether by skin prick test or by measuring specific IgE levels in the blood, RAST. Intermittent symptoms less than 4 days per week or less than 4 consecutive weeks per year. Persistent symptoms more than 4 days per week and more than 4 consecutive weeks per year. Mild symptoms: normal sleep, normal daily activity, normal work in school, no troublesome symptoms. Moderate to severe: one or more items, abnormal sleep, impairment of daily activities, sports, leisure, problems caused at school or work, troublesome symptoms. Figure 91.1 classification of allergic rhinitis reproduced with permission. Prevalence. The prevalence of allergic rhinitis varies widely around the world. The International Study on Asthma and Allergy in Children (ISAAC) 1 and its follow-up ISAAC3 showed the prevalence of rhinoconjunctivitis to vary between 0.82 and 39.7% in different populations. Countries with a low prevalence of asthma, less than 5%, such as Indonesia, Romania, and Greece, has a low prevalence of allergic rhinitis. Conversely, countries with a high prevalence of asthma, more than 30%, such as United Kingdom, Australia, and New Zealand, has a high prevalence of rhinitis, 15 to 20%. There has been a steep increase in the prevalence of allergic rhinitis over the last 40 years, though this may now be slowing. The reasons for this increase are uncertain. Children who live on farms and have contact with livestock are less likely to develop allergic rhinitis than their urban peers, suggesting a possible protective effect of microbial exposure. Larger family size, more frequent infection, and unhygienic contact may all be protective. The hygiene hypothesis. This suggests that reduced exposure to infective agents reduces the Th1 response and leads to an overdrive of the Th2 immune response, leading to an excessive production of IgE and consequent atopy. There are, however, some uncertainties about this concept. Chronic parasitic disease, for example, with worms, is also protective, possibly because of the production of block antibodies, IgG4. Eradication of worm infestation increases skin reactivity to aeroallergens. All these reasons suggest that an urbanized Western lifestyle promotes the development of allergic disease. The link with helminth infection may also point the way to future treatment options. Natural history. Genetic factors are certainly involved in the etiology of allergic rhinitis. Having patients who are atopic may increase the risk of a child having an allergic disease by 3 to 6 times. Exposure to an allergen is also required before sensitivity develops. Therefore, environmental factors are also important. Pollen-induced allergic rhinitis is uncommon before the age of 2, suggesting that exposure over 2 seasons is required for sensitization. The atopic match in children refers to the sequential development of allergic disease, often stating in infants with atopic eczema that the development of all allergen rhinitis and finally allergic asthma. Several studies have shown that adult onset asthma is more likely to occur in patients with allergic rhinitis than those without, usually increasing the risk by a factor of 3. Though whether allergic rhinitis is an earlier manifestation of allergic disease in patients who will go on to develop asthma and whether the nasal disease itself causes asthma is unclear. Remission of symptoms may occur over time. One study showed that although the overall prevalence of allergic rhinitis increased from 12.4 in 1992 to 15% in 2000, in keeping with the worldwide increase. 23.1% of patients who had allergic rhinitis in 1992 no longer had symptoms in 2000. Symptoms of rhinitis generally becomes less severe with age, and skin prick test shows less reactivity in the elderly. Sneezing, nasal blockage, and or itching of the nose. Young children may simply present with block. Other complaints such as itchy eyes, pharyngeal itching, hearing loss due to otitis media with effusion, atopic eczema and asthma, loss of smell, chronic cough, snoring, fatigue, sore throat, and halitosis may occur. Unilateral symptoms: mucopurulent rhinorrhea, thick postnasal discharge, epistaxis pain, and anosmia are not usually associated with allergic rhinitis and should promote further investigation. The history is crucial. When symptoms started, how long they last, and when they occur will allow determination of likely long-term atopy, whether the problem is persistent or intermittent, and the possible allergens. Ask direct questions regarding symptoms suggestive of asthma, such as wheeze or cough. A family history of atopy is important as it makes the diagnosis of allergy more likely. Symptoms of rhinitis: conjunctivitis, cough, and wheeze during the summer months suggest grass pollen sensitivity. Walking with a blocked nose might be linked to a house dust mite in the bed. The main presenting symptom and their severity should be determined. Does the nasal block cause problems with sleep or work? Ask about the character of the nasal discharge. A colored discharge suggests infection. Whether the discharge is usually clear in allergy. Does the block switch from side to side? This is common in patients with mucosal inflammation and less likely with anatomical abnormalities alone, such as septal deviation. More direct questions should be asked regarding endocrine problems that may cause rhinitis. Hypothyroidism and medication. The combined oral contraceptive pills may cause congestion. Specific questions may be helpful in patients with seasonal symptoms. Tree pollen allergy. Birch, particularly, may be associated with oral allergy syndrome, which causes swelling or twingling of the lips when eating uncooked fruits and vegetables such as potatoes, carrots, cherries, celery, apples, pears, plums, peaches, parsnips, kiwi, hazelnuts, and apricots, and is found in approximately half of patients with birch pollen sensitivity. It may also be reported with other pollen sensitivities. Key points: allergic rhinitis is an IgE mediated disease. In Western societies, it is common, more than 20%. It is often associated with other allergic diseases such as allergic conjunctivitis and asthma. It may have significant negative effects on sleep, work, and study. Patients with allergic patients are more likely to be allergic. Lack of helminth infection may be important in development of the disease. Allergic disease is often less severe in the elderly. Examination. A general examination of the patient may reveal other signs of atopic disease such as eczema or allergic conjunctivitis, and sometimes an allergic crease may be seen on the patient's nose. Examination of the nose should always be performed if only to exclude causes other than allergy. Anterior rhinoscopy will allow an assessment to be made of the color and state of the nasal mucosa and to see whether it is swollen and causing obstruction. It may be edematous, blue or pale in color and covered in thin mucus, but this is not always the case. In children, a blocked nose with normal nasal mucosa may suggest adenoid enlargement. Endoscopic examination will allow polyps and other nasal disease to be excluded. In severe or atypical presentation, especially in presence of cartilage or mucosal loss, cosmetic changes, systemic illness, or refractory bleeding, exclusion of other inflammatory or neoplastic disease is important. A history suggesting asthma, such as wheeze or nighttime cough, may necessitate examination of the chest or referral to a respiratory physician. Diagnosis. For many patients, a clear history that fits with allergic rhinitis and a corresponding nasal examination will allow a diagnosis to be made confidently. Though in specialist practice, skin prick tests will normally be carried out as part of the standard workup. If there is diagnostic uncertainty or if the consequences of a possible allergy are important, such as a pet allergy, then allergy testing should be performed. This will normally be either a skin prick test (SPT) or measurement of specific IgE in the blood, often referred to as a radioallergosorbent testing or RAST. Skin prick testing is usually the preferred option as it allows the patient to see results directly and gives time for the patient education about avoidance measurements if required. The method of skin prick testing involves the use of a small lancet to introduce an allergen into the skin. If the patient is sensitized to the allergen, then IgE sensitized mast cell will degranulate and cause a wheal and flare reaction in the skin. Negative saline and positive histamine controls are also used to rule out dermographism and non-reactivity respectively. If the negative control shows a reaction or the positive control shows no reaction, then blood IgE levels should be measured. If an oral antihistamine has been taken in the preceding 7 to 10 days, then the positive control may not react. The positive reaction is noted by a wheal size 2 mm or greater than the negative control. In the United Kingdom, the main 4 allergens that should be tested for are grass pollen, house dust mite, cat and dog, but the prevalence of sensitivities varies around the world, with cockroach sensitivity common in tropical countries. Patients with particular exposure can have various other allergens tested depending on their history. For example, exposure to horses or moles. It should be noted that a positive skin test shows atopy, but it does not necessarily mean that the patient has clinical relevant reaction to that allergen. The reaction has to be correlated with the patient's symptoms. Approximately 25% of adults have a positive reaction on skin prick testing, but only 10 to 15% are symptomatic, though some patients with positive tests will go on to develop allergic disease in the future. RAS testing is usually reserved for patients who require a diagnosis but where SPTs are unavailable or inappropriate. A blood sample is taken and or radio or enzyme labeled anti-IgE is added to the serum. A positive result is shown by an IgE level of 0.35 kilo units per liter or greater. As for SPTs, a positive result may not necessarily be clinically relevant. Nasal allergen challenge is the gold standard of allergy diagnosis, but it is infrequently required or available. It may be useful where the history is suggestive of a particular allergen being responsible for symptoms, but the skin prick tests are negative. An allergen is applied to the nasal mucosa or the patient's exposure to an airborne allergen, and subjective measures made, symptom scores as well as objective measurements, sneeze count, peak nasal inspiratory volume, flow, rhinomanometry, pulmonary peak flow, etc. This method of testing can also be used in patients suspected of having salicylate intolerance using lysine aspirin applied to the nose, and it is possible substitute for an oral salicylate challenge. Nasal challenge testing is complex and has the risk of inducing anaphylaxis and is therefore is used only in specialist centers. Various other methods of determining sensitivity are also described, including the measurement of inflammatory mediators such as histamine, PGD2, leukotrienes, kinins, and tryptase in blood or nasal secretions, nasal cytology and histology, and measurement of nitric oxide in exhaled air. None of these methods are generally used in clinical practice. Some symptoms of asthma may indicate the need for respiratory assessment with pulmonary function tests and reversibility with a bronchodilator. Treatment of key points. The history and symptoms are crucial in diagnosis. The timing of symptoms will often lead to diagnosis in the allergy. Nasal examination is mainly excluded the causes. In severe or atypical presentation, especially in the presence of cartilage or mucosal loss, cosmetic changes, systemic illness, or refractory bleeding, exclusion of other inflammatory or neoplastic disease is important. Ask about asthma symptoms, wheeze and cough. Skin prick testing is useful, particularly in persistent allergic rhinitis where the cause may not be clear. Thank you.